Hello everyone, happy morning, a very good morning. I hope and I believe all of you are doing well. A quick note whether I am audible and visible. Am I audible and visible, everyone? All right, that's great. So, welcome everyone to this YouTube live session where we are going to discuss the clinical MCQs and we have the mnemonics as well today. And the topics that we have in the clinical MCQs as well today are very, very important. And let's start with the discussion of that. Before that, the updates for the students who are new here, what's happening on the platform. So we have Resolve 2023 and Dream Big for 2023. That is, you get 23% off on all the Unacademy Medical PG subscriptions, which includes the NEET PG live subscription, which includes the Vitals. What is Vitals? The recorded sessions, the sessions that have been recorded in the studio. These are not the live classes which are available as recorded sessions. And also the Short 150 subscription, which is under the Mnemonics goal. Even that is now available at 23% off. So the Short 150 course you can now avail at less than 3K with a 23% off and the credits that you might have in your account as well. And with the Vital subscription, the launch price that we have for 12-month subscription is just 11.5K. And the longer the subscription you have, the more cost effective it is. You can also take a combo subscription that is Vitals and Live both together. For the next students, the 12-month subscription is at around 20K for both combined. So you can use the code Dr. Nikita to avail this subscription. And yes, this is the ongoing 150 short topics course that is going on. We have started on December 20 and this will go on till January 16 or maybe January 17 to extend the classes. Right now, there are 25 lessons here in this course. We have completed 12 classes so far. The next class in Short 150 we have today at 11:30 a.m. where we are going to discuss the topics of parasitology, egg identification tricks. Then we have rickettsia. There was a question in recent INICT as well in both of these topics. We'll combine rickettsia with the various vectors in PSM, how to identify and what are the diseases transmitted. And then we will do the topic of CD markers and lymphoma as well in the today's Short 150 class, which is at 11:30 a.m., 11:30 to 1 p.m., 1.5 hour classes every day. And the NEET PG Vitals, a quick update about that. So it's around 800 plus hours of recorded classes. And the practice questions are also there at the end of each topic. The launch price, the special price is 11.5K. You have these subjects which are available right now with the Vitals. The rest of the subjects will be available soon. By February, we will have the rest of the subjects also available in the recorded classes. And we have the ultimate practice high yield batch for the NEET PG students here. We have the IPQs and the PYQs focused batch. January will be all image based questions. February will be all previous year questions that you would see in this batch. And you can get the 3-month subscription at just 9625 with the ongoing offer. Right. So, Anjali, when will the module of KBMD start? In plus, it's going to be after the Short 150 is over. Bhakti, I hope all well. I would love to know the reason for your this comment. Ultimate batch, yes, is included in the plus. So the current plus subscribers, you will get an access to this already. And yes, everyone here, so wishing you all a very, very happy new year in advance. So today is the last day of the year, time to look back and see how, how the last year has been, time to make some resolutions for the next year, and more important, time to be grateful for whatever we have been blessed with in the last year. It's very, very important to practice gratitude, because I've experienced it myself. The more gratitude you practice, the more opportunities you get to be grateful. So make sure you are grateful for whatever is happening or whatever has happened in your life, because there's a reason for whatever happens. We might not understand the reason right away, but sooner or later, as the time goes, you will definitely be grateful for whatever is happening in your life, right? So let us start with the discussion of today's Fast 5 clinical questions and the Fast 5 mnemonics as well. Okay? So let's start with this. The first question here. Oh, all right, Bhakti, I get it. I was just curious to know why did you write that, but it's absolutely fine. You have that freedom of speech. So, it's always going to be like that. One thing you buy at X price, and the next day itself, you might get to know that there's a sale which has come. So some things which are not in our control. Okay, so let us see this. Majority of the patients, I'm saying, I'm so bad. So majority of the people here have commented as A. So why A? Why majority of you have answered A here? Autoimmune. Why autoimmune? Are you seeing any antibodies which are positive here? Are you seeing any antibodies which are positive here? The TPO antibody is negative. The last line, the anti-thyroid peroxidase antibody is negative. So that is not autoimmune. There's no antibody there. Right. What do you think? Who has got it right? I can see someone getting it right. Very good, Supriya, Aruna, and Sania. You have answered it correctly. The correct answer here is D, that is medication adverse effect. Right. So through this question, basically, I wanted to highlight the topic of lithium ka side effect. Lithium adverse effects. Lithium itself is a very, very important topic for your exam and repeated so many times. So what do we have here is, the question is, which of the following is most likely cause of these findings? Anti-TPO antibody is negative. The last second line gives you a clue that this is something related to thyroid. And it is given that this patient has bipolar disorder, diabetes, hypercholesterolemia, and the patient is on metformin, lisinopril, and lithium as well, which is a drug which is used for bipolar disorder. And what does the patient have now? There is fatigue, there is muscle weakness, and the voice has become hoarse, right? And there is weight gain. And what else do we have here? The pulse is 50 per minute. That means there's bradycardia. And examination may, there is cold skin, coarse hair, enlarged thyroid gland, right? Deep tendon reflexes are depressed. The TSH level is 25. Any comments on the TSH level, guys? Any comment on the TSH level when the TSH is 25? Is it low, is it high, or is it normal? Normal for our questions, let's consider that normal up to 5 should be considered normal TSH. So this is the TSH level which is increased. When the TSH is high, can it be pituitary dysfunction? No. When it's pituitary dysfunction, the TSH will not come from the pituitary, right? So that is why this rules out pituitary dysfunction when the TSH is high, right? So one option we have ruled out here. We have ruled out autoimmune thyroiditis because there are no antibodies here. This is not iodine deficiency, very, very unlikely. And this is not also granulomatous infiltration that we are thinking about. All of this is basically the lithium ka side effect. Medication adverse effect. Which medication? It is the side effect of lithium. Okay, that's the side effect of lithium. So lithium, remember, can cause this thyroid dysfunction, TH for thyroid. It can cause thyroid dysfunction. A lot of patients who are started on lithium can present with this thyroid dysfunction, and there's no need to stop lithium with that. Okay, what are the other side effects that we see with lithium? So first of all, lithium has a narrow therapeutic index. That means the safety is comparatively less. That means it can show a lot of toxicity. If the levels go from here to here, there can be toxicity. So we need to do the therapeutic drug monitoring for lithium. What are the toxicity features of lithium? Remember, important one, it can cause tremors. Tremors is frequently given in the question. It can cause nystagmus as well, tremors, nystagmus. It can cause thyroid dysfunction, and you can also have lithium induced diabetes insipidus. Okay, that's lithium induced diabetes insipidus. And another important question here, what is the drug of choice for lithium induced diabetes insipidus? What are the drugs of choice in diabetes insipidus? Central diabetes insipidus and nephrogenic diabetes insipidus. Central diabetes insipidus means the ADH is less, so we supplement ADH from outside. So we give desmopressin, external supplementation desmopressin. Nephrogenic means it is the kidneys which is resistant. The ADH levels are high, but the kidneys are not responding. So in that cases, we give thiazides. Okay, we give thiazides. But we do not give thiazides in lithium-induced diabetes insipidus. This is one of the recently asked questions as well. Why do we not give in lithium-induced diabetes insipidus? Because the reason is that thiazides by themselves can increase the toxicity of lithium. Thiazides increase the toxicity of lithium. How? By increasing the reabsorption of lithium. So therefore, with lithium, we give amiloride. Okay, amiloride is the drug of choice. Remember, lithium, Li is Li ulta. If you see amiloride, that is the drug of choice for lithium-induced diabetes insipidus. Okay, that is the drug of choice for lithium-induced diabetes insipidus. Amiloride is the drug of choice. Amiloride is also the drug of choice for another Li. One is lithium-induced diabetes insipidus, and the other one is Liddles. Okay, and the other one is Liddles. Remember that amiloride is the drug of choice in lithium-induced diabetes insipidus and in Liddles. Right. So that was about this question. A lot of concepts that we have learned here. Okay, a lot of concepts that we have learned here. Now, going to the next question here. Now, since one more point here, since we were at the thyroid dysfunction wala discussion, can you tell me some other drugs which can cause a thyroid dysfunction? Important in pharmacology, which are the other drugs that you read about thyroid dysfunction? Remember, thyroid iodine wala is amiodarone. Right, amiodarone, iodine wala amiodarone, and we have discussed in the recent short 150 as well. It is the TB drugs. Which are the TB drugs that can cause thyroid dysfunction? One is ethionamide, TH again thyroid, and another one is PAS, para-aminosalicylic acid. Okay, para-aminosalicylic acid as well. So ethionamide and PAS, these are the drugs that we have seen in the recent short 150 as well. Okay, right. Let's go to the next question here. Question number 2. Please tell me, what do you think is the answer to this one? – 37-year-old man, bowel movements containing bright red blood in the past 6 hours. Which of the following is the most likely causal organism? Always in the lengthy question, try to read the last line first. Read the options, that gives you a hint into what this question would be related to. Again, so I see that many of you have been trapped here. So the today's questions are a bit tricky ones. Okay, Pavitra, the short 150 classes will be completed by 17th January, the ongoing one on the platform of Unacademy. Okay, so I see some students are getting this right. So Supriya, Bunny, Soshna, and the correct answer here is the option E. It is not E-Tech. It's not enterotoxigenic E. coli. You are correct in the sense that E-Tech, enterotoxigenic E. coli, is the one which causes T4T, that is traveler's diarrhea. Okay, it causes traveler's diarrhea. But this is not traveler's diarrhea. Just the history of the recent travel to a trip somewhere does not mean that this is going to be traveler's diarrhea. The history here that the bowel movements containing bright red blood containing diarrhea. Bloody diarrhea differentiates between E-Tech and EHEC. E-Tech, the traveler's diarrhea, is watery diarrhea. Rather, all of these options, Clostridium difficile, which causes pseudomembranous colitis. Even Clostridium perfringens can cause diarrhea. Cryptosporidium, especially in immunocompromised patients, HIV positive patients. These are all of these, option A to D, these are the causes of watery diarrhea. While E. coli O157H7, this is the one which causes hemolytic uremic syndrome, though the patient here does not have hemolytic uremic syndrome. But remember that H for HUS and H for hemorrhagic diarrhea. Okay, that is bloody diarrhea. And this EHEC is the one, bloody diarrhea, that means dysentery, similar to Shigella. So this has Shiga-like toxin. Okay, this has Shiga-like toxin. So this one word here, the bright red blood in the stools, that tells you that this is bloody diarrhea, and that is why this one here is E. coli O157H7. So remember this O157H7 is the one which causes hemolytic uremic syndrome, and it is causing features similar to Shigella. The toxin is the Shiga-like toxin. And tell me, what is the mechanism of action of this Shiga-like toxin? Does it increase cyclic AMP? Is it EF2? Is it something else? What is the mechanism of action of this Shiga-like toxin? Yes? Absolutely right, Krishnakant. Correct. So the mechanism of action of this Shiga-like toxin of O157H7. Remember Shigella and Shiga-like, read it like or pronounce it like Shikshti. That means it inhibits the 60S subunit of the ribosome. That means it inhibits the protein synthesis. The mechanism of action is inhibiting the protein synthesis by inhibiting the Shikshti-S. Shigella, Shiga is 60S. Okay, pronounce it like that. So it acts on 60X. Right. So, and what is the mechanism of action of E-Tech? The enterotoxigenic E. coli. One toxin is heat stable. Another toxin is heat labile toxin. So the mnemonic to remember that is stable on the ground, that is cyclic GMP. On the ground is GMP, labile in the air, that is cyclic AMP. So stable on the ground and labile in the air, so cyclic AMP and cyclic GMP. That is the trick to remember for E-Tech, the toxin mechanism of action for E-Tech, right? So that was about this question. Most important clue here, this is the blood in diarrhea, and that tells you that this is O157H7. The rest of them are watery diarrhea. For Clostridium difficile, the pseudomembranous colitis, we generally have the history of a person taking some antibiotics which destroys the normal flora. So this Clostridium difficile overgrows. Right, here there is history that the patient does not take any medications. There is no history of serious illness, like no HIV, nothing is there, no cryptosporidium. This is not pseudomembranous colitis. Okay? Yes. So this has been given, the travel history has been given particularly purposefully for the creating the confusion. Right? So that is why we should be very, very careful while solving these questions. Okay. Let's go to the next question now. This is question number 3. What do you think will be answer to this one? Okay. So I see some people getting confused between option A and option B. What do you think? What is the diagnosis that you have made in this patient here? Absolutely right. So this is myasthenia gravis. What are the clues here? So this is a patient who's presenting again with muscle weakness and fatigue. And where did it begin? It began in the muscles of the face and then it progressed to all the muscles. There is ptosis, there is a left abducens muscle palsy, and the X-ray chest shows a mediastinal mass. So all these clues here, what is this mediastinal mass here? Putting all these dots together, connecting the dots. The mediastinal mass here is thymoma. Remember the association of thymoma with myasthenia gravis. Okay, remember the association of thymoma with myasthenia gravis. So this is a patient of myasthenia gravis with the fatigue, and it starts with the facial muscles and then it progresses to the rest of the muscles. It can even cause the respiratory muscles weakness. And what kind of lung disease can it lead to? Is it restrictive lung disease or obstructive lung disease? Because the muscles are weak, so the expansion will not be there. So this is going to cause restrictive lung disease. Okay, remember that myasthenia would be restrictive lung disease. What kind of hypersensitivity reaction is myasthenia gravis? What kind of hypersensitivity reaction is myasthenia gravis? Yes. So previously it was type 2 hypersensitivity reaction because it is antibody mediated. What is the antibody for? The acetylcholine receptor post-synaptic. It's not the pre-synaptic. Remember, it's a post-synaptic acetylcholine receptor antibody. But now this has been put into the type 5 hypersensitivity reaction where we have the antibodies to the receptor. So myasthenia gravis and Graves, these are the ones which are put under type 5 hypersensitivity reaction. Right. Myasthenia gravis, the weakness, fatigue increases more in the evening. Right. With the muscle use, there is more fatigue. So evening may the patient becomes more fatigued. And what are the other things that we need to know for myasthenia gravis? So the diagnosis can be established by nerve conduction studies with repetitive stimulation that will induce the fatigue. The MRI of cervical spine. MRI of cervical spine, why will there be ptosis and why will there be the abducens muscle? Why will there be cranial nerve involvement? Right? Why will there be cranial nerve involvement with the cervical spine involvement? Right? So that is why this is not the answer. Biopsy of a peripheral nerve can be done for neuropathy, neuritis. Biopsy of a skeletal muscle can be done for myositis like polymyositis, dermatomyositis. But this is not going to help here. So what drug do we use for diagnosis and what drug do we use for treatment in myasthenia? So remember that the test, the diagnosis test that used to be done, now we do the nerve conduction test. But for our exam, we need to remember it's Ensilon test, which is the drug used here is edrophonium. Still, it's a frequently asked question. Remember edrophonium, the DR, that is doctor, makes the diagnosis. So edrophonium is for diagnosis. What is edrophonium basically? How does edrophonium help in diagnosis of myasthenia gravis? Edrophonium is the acetylcholine esterase inhibitor. It's an anti-choline esterase. So what will it do? It will increase the acetylcholine levels. So what will happen? The increase in acetylcholine levels, they will improve the symptoms. Okay, they will improve the symptoms. So this is how we can differentiate myasthenia gravis from cholinergic crisis. Okay, where the fatigue is because of the cholinergic crisis. With increased acetylcholine, it would worsen. Here, if there is improvement, then it means myasthenia gravis. For treatment, remember to get rid of myasthenia gravis. It is pyridostigmine. Again, another drug which is acetylcholine esterase inhibitor. So it increases the acetylcholine levels. It is longer acting as compared to neostigmine, and that is why we use pyridostigmine. Okay, we use pyridostigmine. So remember that pyridostigmine is the drug of choice for treatment. We can also use neostigmine, but it is comparatively shorter acting. Okay, it is comparatively shorter acting. So that was about the diagnosis, and that was a quick review about myasthenia gravis. What we also need to know the comparison with the Lambert-Eaton syndrome, right? The Lambert-Eaton. What is the difference between myasthenia gravis and Lambert-Eaton? So if I draw the synapse here, in Lambert-Eaton, the antibody is against the calcium channel, which is presynaptic. So in Lambert-Eaton, it is against the presynaptic calcium channel. In myasthenia gravis, it is postsynaptic acetylcholine receptor antibody that we have. In Lambert-Eaton, we also have the autonomic symptoms which are not present in myasthenia gravis. The deep tendon reflexes are also affected, right? The deep tendon reflexes are also affected, and we have opposite that with increase the use, there is the patient feels better. With increased use, the patient feels better. These are some of the points that we should remember for Lambert-Eaton versus myasthenia gravis, right? So myasthenia gravis is asked very, very frequently with the clinical scenario. And remember these points. What is the HLA associated with the myasthenia gravis? What is the HLA with the myasthenia gravis? Right, HLA with myasthenia gravis, MG. MG is, right, MG is like, remember Mahatma Gandhi's spectacles, which is that figure of 8 appearance. So that is HLA B8. Okay, HLA B8 is what it is associated with, right? So that was about this one, and going to the next question now. Okay, so another lengthy question here just to give you practice for all the types of questions that can be asked and discussing the relevant topic. So always in lengthy question, again, read the last line first. So which of the following is the most likely explanation for these findings? So there is a history of syncope, there is a history of shortness of breath and sweating, there is a childhood history of asthma. The patient is also a patient of panic disorder. Right. So again, I see majority of the students have been trapped here with the clinical history that has been given. So no, this is not a panic episode. No, just still waiting for someone to get the right answer here. Yes, Anjali, correct. Denhouse and yes, Bhakti. The correct answer here is pulmonary embolism, right? That's pulmonary embolism here. It is not a panic episode. This is not a panic episode because a panic episode will not lead to hypoxemia. The PCO2 is 30, the PO2 is 62, which is less. That means that there is hypoxemia and the history of syncope along with the shortness of breath. Right, all this is pulmonary embolism. Panic episode will be diagnosed only when we rule out the rest of the primary organic causes of the shortness of breath and sweating. Right, and correct. We also have the patient here whose blood pressure is on the lower side. That means there is hypotension. Okay, that means there is hypotension. So this is most likely pulmonary embolism, which presents with shortness of breath and there can be a history of syncope as well, which we are seeing here, and the PO2 which is decreased. Why the patient has developed pulmonary embolism? Because this hint here that the patient is on oral contraceptives. So that is a pro-thrombotic state, which is one of the predisposing factors for developing pulmonary embolism. Okay, for developing pulmonary embolism, right? So panic episode will be diagnosed only when the rest of them have been ruled out, and there will not be hypotension here. The blood pressure is on the lower side here, right? And another important point in panic episode, the AA gradient, that is the alveolar arterial gradient, would be normal, right? The gradient would be normal. In pulmonary embolism, there is the VQ mismatch, the ventilation perfusion mismatch, that can lead to increased gradient here, okay? So this is the pulmonary embolism. So talking about some investigations in pulmonary embolism, what is the screening test that we do for pulmonary embolism? It is the D-dimer test. Okay, it is D-dimer. What is the investigation of choice? Investigation of choice is CT pulmonary angiogram. This is what we are seeing in this image here. So from right to left, we have discussed the vessels are sharp. This is superior vena cava, ascending aorta, and the pulmonary artery. So this is the filling defect that we are seeing here. This is the filling defect that we are seeing here in the pulmonary artery. So this is suggestive of pulmonary embolism. Okay, the investigation of choice is CTPA. What is the most common ECG finding that we see with the pulmonary embolism? It could be normal, and the most common is sinus tachycardia. Okay, sinus tachycardia is the most common. What is the specific sign? It is S1, Q3, T3 pattern that we see with pulmonary embolism in ECG. What criteria do we use to decide whether the patient has pulmonary embolism? It is the Wells criteria, right? Wells criteria, modified Wells criteria is used to basically decide whether the patient has the probability of having pulmonary embolism, right? So all these are the important points for pulmonary embolism that we should be knowing. And yes, what are the chest X-ray signs with pulmonary embolism? We have Hampton's hump, right? Remember, it's the Hampton's hump, not the Hampton's line. There is Westermarck sign. Westermarck sign, Hampton's hump. We have the Pallas sign, and we have the Fishner sign that we see with pulmonary embolism. So Hampton's hump, Westermarck, Pallas, Fishner's, these are some of the signs that we should remember. Remember, it is Hampton's hump. It is not Hampton's line. Okay, so these are the chest X-ray signs of pulmonary embolism. Anatomically, can you tell me what is this structure here? What do you think is this structure here, this one? Hammond's crunch is not here, Dr. Hashirama. Hammond's crunch is when there's air in the mediastinum, the subcutaneous emphysema. Right, that was the INI-CT question. Correct. This is esophagus here, and this is the bronchus. The right bronchus, the left bronchus ke piche we have the esophagus, and this is the descending aorta. Right, this is the descending aorta. Correct. And what is this structure here anatomically, guys? What is this structure here? This is the bone which is present posteriorly behind. This one here is scapula. Okay, this is scapula here that we are seeing. So that's the scapula on both the sides, the posterior bone there. Right, the ribs are these. These are the ribs that we are seeing. Okay, these are the ribs. Ribs ke bhi piche jo hai, wo hai scapula. Correct? Alright, so that was about this question. Now going to the next question here in the fast 5. So these are the lab findings that are given. This is the peripheral smear that is given. What is the most appropriate next step to confirm the diagnosis? So hematocrit 30, MCV 103, and then we have calcium which is 12.2 and creatinine which is 1.8. Let's take your creatinine as 2.8. Right, creatinine is 2.8. So what do you think is the answer here? C. Why will it be C? The serum iron studies. Why will it be vitamin B12? Whenever you're writing the answer here, write your thought also behind that, so that if there's a room, I can correct that. Right, so today's questions were very tricky, it seems. And again, we have been trapped here. The correct answer here, someone got it right. Yes, Kundan, Sneha, Sinchan. The correct answer here is bone marrow biopsy. Why? Because this is a diagnosis not of iron deficiency, not of vitamin B12 deficiency. Here we are thinking about multiple myeloma. Why? What is the crab feature in multiple myeloma? The end organ damage, hypercalcemia, renal failure, anemia, and bone pain. Hematocrit is 30, it is decreased. Less than 35, take it as low. So this is hematocrit 30. Okay, so this is decreased. MCV is 103. What is microcytic and what is macrocytic anemia? When do we call micro and when do we call macro? Micro is less than 80 and macro is more than 100. So this is increased. So the macrocytic anemia is what the patient has. Okay, so that is why iron is out, because iron will cause microcytic anemia. We can still think of B12 because of the macrocytic, but look at the hypercalcemia here, right? The calcium more than 12, creatinine more than 2. That means this is renal failure, this is hypercalcemia, there is anemia, and the patient already has the back pain. So the crab features are already there, and that is why this is multiple myeloma is what we are thinking about. And what is the peripheral smear showing? Right, correct, Dr. Hashirama. So yes, Sunny, what is the peripheral smear showing? These RBCs, which are like sort of clumped together forming a stack, that is the Rolo formation that we are seeing here, which is seen in multiple myeloma because of the hyperviscosity. There is increased viscosity, there is Rolo formation that we are seeing here, correct? So this is the peripheral smear finding, very, very important. Okay, very, very important. So how do we diagnose multiple myeloma? It is by bone marrow biopsy. How many plasma cells should be there? So presence of more than 10% clonal plasma cells with one or more the myeloma defining events, which could be basically the end organ damage, that is the crab, or second is the evidence of one or more high risk biomarkers, which includes more than 60% plasma cell bone marrow infiltration, right? So that is what we should remember here in multiple myeloma. Okay, that is what we should remember here in multiple myeloma. Now, multiple myeloma, let us quickly see the various cells, the bodies that we can see. So we have plasma cell, which has an eccentric nucleus. The other finding we can see is the binucleated plasma cell. There could be plasma blast. Remember this flame cell where we have the cytoplasm, which looks like a flame. Then we have the Russell body and the Dutcher body. What is the difference between the two? Russell body is the cytoplasmic immunoglobulin accumulation. Right, multiple myeloma basically is plasma cell neoplasm. Plasma cells secrete immunoglobulins. So a lot of immunoglobulins are secreted which cannot be degraded, so they accumulate. If they accumulate in the cytoplasm, in the endoplasmic reticulum wala is Russell body that we will see. If it is intranuclear, if it is within the nucleus, that is Dutcher body. Dutcher body is intranuclear and Russell body is cytoplasmic, right? And if there are multiple Russell bodies, they can give this appearance. Imagine like this is a mottled appearance. That is the mott cell, right? All these are basically immunoglobulin accumulations. So mottled appearance, this is the mott cell. So all these images are very, very important. Mott cell, Russell body, Dutcher body, and there is flame cell that we would be seeing. Okay, these are the important features. We might also see this crystalline rods in the plasma cells. Correct? Now, this is one of the image that is asked very frequently in the exam. So what is this image showing? All these, the eosinophilic, the hyaline inclusions, these are of the immunoglobulins. These are the Russell bodies. These are not intranuclear, so cytoplasmic. So these are the Russell bodies that we are seeing. Okay, so these would be seen with multiple myeloma. Dutcher body would be intranuclear, right? The cell with the nucleus, it is intranuclear immunoglobulin, and Mott cell is this mottled appearance, which is cytoplasmic immunoglobulins. Okay, which is cytoplasmic immunoglobulins. And remember what are the good prognostic features? The rest of them are bad prognostic features, right? So just remember these short ones, which are the good prognostic factors. Okay, the good ones, remember the D and the D are the good prognostic factors. That is diploidy, hyperdiploidy, and D for cyclin D1 or cyclin D3. So if you remember, cyclin D1 has been in a mantle cell lymphoma also, where we have discussed overexpression of cyclin D1. So mantle cell lymphoma, what is the translocation? It is 11-14. 11-year-old, 14-year-old siblings fighting and the parents going mental. So 11-14. So that is what we are seeing here as well. Mental and multiple myeloma. The M and the M, they have translocation 11-14. That is cyclin D1. Or 6-14, that is cyclin D3 positive. So diploidy D1, D3 positive is a good prognostic feature. The rest of them are the bad prognostic. What is the most important prognostic factor? It is the beta-2 microglobulin levels. Okay, at the time of diagnosis, the elevated beta-2 microglobulin levels, this is the most important that we need to know, that it is used as a prognostic factor in multiple myeloma. Remember, it is beta-2 and it is microglobulin. It is not macroglobulin. It is not alpha microglobulin. It is beta-2 microglobulin, which is a prognostic factor in multiple myeloma. Correct? Tell me some drugs that we use in multiple myeloma. Proteasome inhibitor, again, that we have discussed yesterday in the short 150. Proteasome is bortezomib. Zome is the proteasome. So all the zomib drugs, right? So we have bortezomib, which is used. We can use dexamethasone, and we also have lenalidomide, which is an immunomodulator that is used in the treatment of multiple myeloma. Okay, that's used in the treatment of multiple myeloma. Yes, what do you see in electrophoresis? Very, very important. We see the M spike. We had seen in one of the recent Fast 5 MCQs, where we see that albumin se bhi zyada upar, we have this M spike, which indicates the monoclonal immunoglobulins that are secreted and that are present in these disorders, right? The disorders of the plasma cells. Correct. So that's the M spike that we have here. So this was about multiple myeloma. And what is the role of bone scan? How important is the bone scan in multiple myeloma? Remember, it's not very important because it gives cold spot. Multiple myeloma gives a cold spot in bone scan because there is no new bone formation. So the alkaline phosphatase levels are normal. Remember this point as well. In multiple myeloma, the alkaline phosphatase levels are normal. There is no new bone formation, so it gives a cold spot. X-ray is better than bone scan for the diagnosis, and right, it's the bone scan will give a cold spot. Okay, and remember that multiple myeloma is radiosensitive as well. So if it is solitary plasma cytoma, we can treat it with radiotherapy. In Paget's, the only thing to be increased is alkaline phosphatase. Right, in Paget's, the only thing to be increased is alkaline phosphatase. Absolutely right. Correct. And what is the appearance of the skull that we see with multiple myeloma? It is the punched out lytic lesions, right? The punched out lytic lesions is what we see, or the raindrop lesions is what we see with multiple myeloma. The punched out or the raindrop lesions. Okay. Now quickly going to the Fast 5 mnemonics. We are done with the Fast 5 clinical questions. I hope you have enjoyed those today. Now going to the mnemonics. Hemolytic anemia is seen in deficiency of which vitamin? No, this is not vitamin K. So again, a confuser here. Hemolytic anemia is seen in deficiency of Vitamin E. Okay, vitamin E. We have discussed again in short 150 this topic. Remember, E for erythrocytes are affected. Erythrocytes lysis, that is hemolytic anemia. Vitamin K affects the clotting. Vitamin K deficiency affects the clotting. That causes hemorrhagic disease of the newborn. It does not cause hemolytic anemia, right? It's hemorrhagic disease of newborn. It is not hemolytic anemia. Remember, it is vitamin E deficiency, which can present similar to vitamin B12 deficiency. It can have the neurologic complaints. But in vitamin E, it's going to be hemolytic anemia. In vitamin B12, it is going to be megaloblastic anemia. Okay, that's the difference. That is important. Next one. All of the following are activated by high insulin glucagon ratio, except which of the following? All of the following are activated by high insulin glucagon ratio, except which of the following? Absolutely right. It's gluconeogenesis. See, high insulin glucagon ratio basically means high insulin, and insulin is an anabolic hormone. It is increased in the fed state. Gluconeogenesis happens in the fasting state, right? It is a catabolic process, and that is why it will not be stimulated by insulin. So remember, it's gluconeogenesis. Fatty acid synthesis is anabolic. Lipoprotein lipase is anabolic. It increases the stores in the body, and glycogenesis is also anabolic. So that is why the answer here is gluconeogenesis. Just give me a minute. Yes, am I audible now? Okay, that's great. Right. So remember that insulin is anabolic, so it will stimulate the processes which increases the stores in the body. Gluconeogenesis happens in the fasting starvation, and that is why insulin will not stimulate that. Okay. Next one. What is the drug of choice in hairy cell leukemia? What is the drug of choice in hairy cell leukemia? Absolutely right. It's cladribine. So remember this as a person who is clad with hair. So hairy cell clad with hair. It is cladribine, which is the drug of choice for hairy cell leukemia. Okay, it's cladribine. What is the CD marker? 103. Right. So remember this. The hair appearance, it is 1. Then the face and the ears, it is 103. That is the most specific CD marker for yes, in hairy cell leukemia. Absolutely right. We have studied this in short 150. So cladribine is the drug of choice for hairy cell leukemia. Next one. What is the CD marker positive in this case? What is the CD marker which is positive in this case? Correct. Absolutely right. Very, very important question. So this is the tennis racket appearance of the Burbick granules that we are seeing here. Burbick granules which are seen with LCH, Langerhans cell histiocytosis. Remember LCH. It is L is 1. So it is CD1A. L is like number 1. It is CD1A. It could be CD207 also, which can be positive. That is Langerhans cell histiocytosis. 103 we said is hairy cell leukemia. 19 is pan B cell marker. CD3 is pan T cell marker. In the today's Sure Shot 150 class, we will see all the CD markers. Right, that's one of the targets for the today's Sure Shot 150 at 11:30 a.m. Right, next one. This disease is also known as, I believe this is the last one. This disease is also known as which of the following? Absolutely right. Again, we have discussed this in the yesterday's class. This is desert rheumatism. Why? Because we are seeing this circle के अंदर multiple circles. Right. So what are we seeing? Circle के अंदर multiple circles, C within C, and that is coccidioidomycosis. And remember C for camel. Where is the camel present? Camel is present in desert. So coccidioidomycosis, camel wala desert, it is coccidioidomycosis. Circle ke andar circle is what we see. So this is desert rheumatism. Okay, this is desert rheumatism. 11:30 a.m. It's on the Unacademy app under the Mnemonics wala goal, right? The Short Shot 150 course which is going on. Absolutely right, Dr. Kalyani. And we said that why is it called rheumatism? Because rheumatism, like in rheumatologic disorders, joint pains is one of the symptoms in coccidioidomycosis. Darling's disease is like, imagine saying hi darling. So it is histoplasmosis. Okay, histoplasmosis is Darling's disease. North American blastomycosis is blastomycosis. South American is paracoccidioidomycosis. Okay, the South American is paracoccidioidomycosis. So this is coccidioido, circle के अंदर circle वाला appearance, right? So that completes the today's YouTube live session. And again, a very, very happy and a prosperous new year in advance to each one of you. Look back upon the year that has gone, take some resolutions for the year that is coming up, and whatever it is, just try to make the best of the resources that you have and each single day that you have. So thank you so much, everyone. And I'll be seeing you at 11:30 a.m. for Short Shot 150 for the students who are subscribed for the same. And yes, Krishna Kant, you should be adding this. If you find it difficult to add it subject-wise, you can just make a separate notebook because that might be more handy to revise, to write down these points. Whenever you see any KBMD Fast 5, you can just make a separate notebook for that. Okay. Thank you so much. Goodbye. Take care and keep studying, keep revising and keep winning. Thank you.